Hello everybody. Today we are going to discuss about the ES-ICM guidelines on the management of shock which are recently published. So the shock is most commonly encountered condition in ICU. So how to define this shock? So shock is defined as life-threatening acute circulatory failure which is characterized by decreased tissue perfusion which leads to inadequate oxygen delivery or oxygen utilization to meet cellular metabolic demand. So, how to identify this shock? So, the typical features of shock are hypotension, tachycardia, signs of hypoperfusion such as abnormal skin perfusion, decreased urine output, altered mental status. So, although hypotension is commonly present, it is not required to define the shock. And the another evidence of the shock is lactate levels are typically high. So we should always measure the lactate level. So clinically, if you want to diagnose shock, so we should look at these parameters like pulse rate, blood pressure, mental status of the patient. And if our patient is in shock, he will show the character. He will be tachycardic, he will be hypotensive, the skin perfusion will be abnormal, patient will be having decreased urine output, and the patient will be in altered mental status. Now, what are the now these this is all about the clinical side. Now about the regional circulation and tissue oxygenation mark. So the serial assessment of tissue perfusion should be performed to follow shock evaluation and also help to assess the underlying pattern and adequacy of cardiac output and vascular function. So what are these regional markers? So monitoring skin perfusion should be performed using the assessment of the CRT, skin temperature and mottling. So we should pay attention to this capillary refill time, skin mottling, and temperature whenever we are dealing with the patient of the shock to assess the response and to diagnose the underlying pattern. Also, if the patient is having central venous catheter, then we should go for the serial measurement of venous oxygen saturation in if our patient is in shock. Also, if our patient is having both central venous catheter and arterial catheter, then the serial measurement of veno-arterial difference in carbon dioxide partial pressure should be performed. So, if our patient is with central venous catheter and arterial catheter, one may consider performing serial measurement of the ratio of partial pressure of CO2 over arteriovenous difference in the oxygen partial content. So, whenever feasible, microcirculation must be considered in adjunct to comprehensive hemodynamic evaluation whenever we are dealing with the patient of the shock. Now, about the fluid therapy. In patient with the persistent shock after initial fluid resuscitation, fluid responsiveness should be assessed before continuing fluid resuscitation. So the potential benefit of the fluid administration predicted by assessment of the fluid responsiveness, and it should be weighted against the potential risk of the fluid administration. Because why it is necessary to assess the fluid responsiveness? Because the patient should respond properly to the fluid that we are giving. If our patient is not responding properly to the fluid, then whatever fluid we are administering to the patient, it will cause more harm to the patient rather than benefit. So how to assess whether the patient is our fluid is causing more harm to the patient rather than benefiting it? So the method of assessment of the harm to the patient is means we can check for the intravascular feeling pressure, intra-abdominal pressure, then extravascular lung water, pulmonary vascular permeability, venous vexus grading we can perform. We can always measure PF ratio and lung ultrasound score. Now, whenever we are dealing with the shock, first we are treating the patient with the fluid. So how much initial means it is always recommended to give first fluid challenge in the form of bolus like 200 to 500 ml over 5 to 10 minutes. And the next step is to assess the response to that fluid challenge. So one may consider assessing the effect of the fluid bolus on cardiac output whenever available. So we should always see the response of that fluid bolus to the cardiac output, or we should always measure the response of the fluid bolus to pulse pressure. We should always consider measuring the pulse pressure rather than the mean arterial pressure. So the effectiveness of the fluid bolus in improving tissue perfusion should be evaluated by measuring variables like capillary refill time, skin mottling, carbon dioxide, partial pressure derived variables, and lactate and central venous oxygenation. So how should one assess the fluid responsiveness? Now, how to assess this fluid responsiveness? So it is always recommended to measure dynamic variables over the static ones. We recommended the passive leg raising test to assess the fluid responsiveness in mechanically ventilated patient in shock with or without spontaneous breathing. Or one must or one must, or it is recommended to go for end expiratory occlusion test, which is alternative to the passive leg raising test in mechanically ventilated patient in shock without spontaneous breathing activity. These guidelines are unable to provide recommendation regarding the use of tidal volume challenge as an alternative to PLR test in mechanically ventilated patient in shock due to paucity and the heterogeneity of the available data. Also, it is recommended, also if the patient is mechanically ventilated, if the patient is not having any spontaneous breathing and the tidal volume is more than or equal to 8, then it is always recommended to go for pulse pressure variation. And we should not measure the pulse pressure variation if the tidal volume is less than 8. Also, we can also means if our patient is mechanically ventilated patient without spontaneous breathing activity, if the tidal volume is more than or equal to 8, then it is also recommended to measure stroke volume variation for assessing the fluid responsiveness. And these guidelines are unable to provide recommendation regarding the use of stroke volume variation to assess fluid responsiveness in mechanically ventilated patient in shock with spontaneous breathing activity. Also, it is unable to provide recommendation regarding the use of mini fluid challenges in patient with the shock. And also, these guidelines are not suggested to you changes in the IVC alone to assess the fluid responsiveness. So, as long as the fluid responsiveness is considered, means we have diagnosed, we are dealing with the one patient who is in shock. So, we want to first go for fluid resuscitation. So, we have given the fluids. Now, we want to assess his fluid responsiveness. So according to this guideline, we can go for passive leg raising test to assess the fluid responsiveness in mechanically ventilated patient. If the patient is mechanically ventilated with or without spontaneous activity. And the alternative method for the passive leg raising test is to perform uh, end expiratory occlusion test if the patient is mechanically ventilated. Also we can go for the pulse pressure variation and the stroke volume variation if our patient is mechanically ventilated, if without spontaneous breathing activity, and the tidal volume is more than or equal to 8 ml per kg. But we should not go for the pulse pressure variation and the stroke volume variation if the tidal volume is less than 8 ml per kg. Also, we should not rely only on the IVC for measuring this fluid responsiveness. So when we should go for the cardiac output monitoring in shock? Cardiac output or stroke volume should be monitored in patients who do not respond to the initial therapy if the patient is not responding to the initial fluid resuscitation, then we should go for the cardiac output measurement or stroke volume measurement. So the frequent reevaluation of the cardiac output may be considered. When cardiac output is monitored, its adequacy should be interpreted by evaluating organ function, tissue oxygenation, metabolism, and perfusion. So, how should one monitor the cardiac output in shock? So, transpulmonary thermodilution and pulmonary artery dilution with pulmonary artery catheter may be considered in patients for whom cardiac output monitoring is required. So transpulmonary thermodilution or pulmonary artery catheter in patient with shock and moderate to severe ARDS may be considered be used for guiding fluid therapy. So the pulmonary artery catheter may be considered in patient with persistent shock and the RV failure after cardiac surgery in addition to the serial echocardiography. So less invasive cardiac output monitoring device could be used if these have been proven to provide accurate estimation of cardiac output for this specific context over more invasive ones like pulmonary artery catheter and transpulmonary uh, thermodilution. That means what I want to say is we can use this pulmonary artery catheter for measuring cardiac output. But if less invasive devices are available like echo, then it is better to go for the serial measurement of the echocardiography rather than pulmonary artery catheter. So it is always recommended to use echocardiography as first line imaging modality to assess the type of shock and for the hemodynamic status. Serial echocardiographic evaluation should be performed to provide additional information of cardiac output, cardiac function, even when cardiac output is monitored. So when and how should one monitor arterial pressure? So arterial pressure should be monitored in patient with the shock. Arterial pressure should be monitored with arterial catheter in shock who is not giving appropriate response to initial therapy and who are requiring vasopressor infusion. So let's talk about the target arterial pressure in the shock. So target blood pressure should be individualized during resuscitation of patient with the shock. So septic shock, the target map should be 60 to 70. So higher MAP per target may be considered in patient with septic shock and the history of chronic arterial hypertension. Higher MAP target must be considered in patient with septic shock and high CVP who show the clinical improvement with the high blood pressure. So if we are dealing with the hemorrhagic shock, then go for the lower MAP because of the concept of permissive hypotension. Because in the conditions like hemorrhagic shock, we should not target the higher BP because by targeting higher BP, we are increasing the chance of the chance of the bleeding will be more. Whenever we are dealing with the patient with the traumatic brain injury, we should target the MAP of more than 80 mmHg. And the initial phase following trauma, the target systolic blood pressure of 80 to 90 mmHg should be monitored until major bleeding has been stopped when there is no clinical evidence of the traumatic brain injury and coma. So please remember, whenever we are dealing with the hemorrhagic shock, we should always target the lower MAP. That is MAP of 50 to 60 mmHg is that is MAP of 50 to 60 mmHg is appropriate, but there should be absence of traumatic brain injury. Whenever we are dealing with the patient of traumatic brain injury, we should always go for the higher MAP because we should not compromise on the circulation of the brain. So for if we are dealing with the cardiogenic shock, then we should target the MAP of more than 65 mmHg. So the next question is, when should measure the intra-abdominal pressure? So whenever we are suspecting this patient has high chance of going for intra-abdominal hypertension, then serial measurement of intra-abdominal pressure should be considered. Like whenever we are dealing with the patient of pancreatitis, then this patient having the high chance of developing intra-abdominal hypertension. So it is so during resuscitation phase only, it is always recommended to measure intra-abdominal pressure. Also, CVP should be measured whenever the patient is having central venous catheter. Pre-specified CVP value should not be targeted during resuscitation of patient with the shock. So we suggest performing, so it is always recommended to perform one or more echocardiogram in patient with the circulatory shock. Also in patient with the shock, echocardiography defined phenotype of left and the RV systolic function may be of prognostic significance. In patient with the circulatory shock, echocardiography leads to changes in the management and supports the therapeutic impact. Thank you guys.